Good afternoon, everybody, and welcome to the CGNE seminar series for today. I see people are still kind of jumping on Zoom from the waiting room, but I'll just go ahead and start with our land acknowledgement. The Pennsylvania State University campuses are located on the original homelands of the Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, and Wazazi nations. As a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the longer history of these lands and our place in this history. Okay, so just a couple of announcements and disclosures that we always start with. The Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we do not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-evaluation survey must be completed. This seminar is being recorded. You can ask questions of our great speaker, Beth Ann White, either using the Q&A device at the bottom of your screen or in the chat. We will monitor either way. If you feel like unmuting and asking it yourself, you can of course raise your hand and we will unmute you so that you can ask the question directly. We will have a post-event evaluation survey link, and we'll place that link into the chat after Beth Ann has completed her presentation. Give you all a few minutes to get started with that. And if you would please complete that within a week, that will allow you to get the necessary or fulfill the necessary requirements for the continuing education credits for RNs if you are looking for that. You'll also be emailed a link to the survey within 24 hours of the survey. And we ask that everybody completes that if you would please, just so that we can get some important evaluation information, help make our seminars better, and collect needed data for our Age-Friendly Care PA project. The Nursing Continuing Professional Development Certificates will be emailed to those RN participants who meet all the requirements within 1 month following the seminar. If you have any questions, feel free to reach out to the CGNE at their email, cgne@psu.edu. All right, so next, I would love, and I probably should have said, hi, I'm Diane Barish. I'm not Beth Ann White, even though it says that. But I am Diane Barish, an assistant research professor here at the College of Nursing. And I would like now to introduce Tracy Kephart. She is one of our DNP students. She is also one of our fabulous nursing instructors at the Altoona campus. She was awarded at our spring 2023 brunch, at the CGNE brunch. She was awarded our DNP student champion for her quality improvement project titled Nursing Safety Huddles for a Long-Term Care Facility. So we're very happy to have Tracy with us today, and she will introduce our speaker. Thank you so much, Tracy.
Thank you, Dr. Barish. I appreciate that. And it is an honor and a privilege to introduce Dr. Beth Ann White as an associate teaching professor and coordinator for the Family Nurse Practitioner and Adult Gero Primary Care Nurse Practitioner programs. Dr. White is a graduate of Geisinger School of Nursing, where she received her diploma in nursing. She received her bachelor's degree in nursing, master's of science degree in nursing with an adult nurse practitioner option, and a doctor of nursing practice degree with an emphasis on leadership from Penn State University. Her DNP project focus was oral care and long-term care. She received the 2018 DNP Student Champion Award from the Penn State Teresa Neese and Helen Diskovich Center of Geriatric Nurse Excellence, where she holds affiliate faculty status. Dr. White also received the 2020 Janet A. Williamson Excellence in Teaching Award from the Penn State Ross and Carol Neese College of Nursing. Dr. White is currently participating with the ECHO Long-Term Care RISE project with the Penn State College of Medicine. In addition to teaching, Dr. White continues to practice as a certified registered nurse practitioner for Geisinger, and she sits on the board of directors for the Primary Health Network, which is the largest FQHC in Pennsylvania. Welcome, Dr. White.
Thank you, Tracy. It's an honor to have you introduce me as well, in being together and helping mentor you as well. So thank you so much. Thank you so much. So to begin, I'd like to share my screen. And can everyone see my screen? I think it may have just popped up. Are we good?
Yes,
Yes.
I can see it. We're good.
Okay, great. Thank you. And I'm honored to be here today to talk about one of my favorite topics, polypharmacy and deprescribing. And where do we start and how do we do it? So we're going to make that our focus today. To begin with, I have nothing to disclose. And our objectives today are really to help you understand how to identify which medications that we could consider discussing with a patient or an older adult for deprescribing, utilizing the current evidence to support proactive deprescribing practices, and describe the role of the interdisciplinary team as an approach to patient-centered deprescribing. So to start, I'd like to just kind of poll you as the audience, and we need to take a look at polypharmacy, and I just want to see what your understanding of polypharmacy is. So a standardized definition of polypharmacy means that a person is taking how many medications? 2, 5, 7, or 10? And I'll go ahead, actually, the overwhelming response, we have 81% of you that responded, so thank you. And the overwhelming consensus is B, 5 medications. And that is what the literature tells us about polypharmacy. I just need to, whoops. Take the poll question down, and let's take a look at what actually polypharmacy is. So one of the first issues with it is that there really is no consensus definition. It is described quantitatively and qualitatively in literature. It is classified most consistently as the use of 5 or more medications daily. Another definition is that it's medication that a patient takes that lacks any indication, is ineffective, or is duplicating treatment provided by another medication. We see polypharmacy in older adults with multiple chronic conditions, and those chronic conditions are 2 or more in patients with things such as arthritis, asthma, COPD, CAD, depression, diabetes, and hypertension. And unfortunately, or fortunately, however you look at it, our disease state guidelines to treat many of these chronic conditions really do contribute to polypharmacy. And I have seen in the literature now the new term, instead of trying to quantify polypharmacy, they are talking about appropriate polypharmacy, so justifying why someone is on multiple medications. When we look at the patient with polypharmacy, there are definitely some risks associated with this. We do see patients who have multiple medications have an increase in mortality, definitely an increased risk for falls, fragility, frailty, and disability, adverse drug reactions, and this risk for adverse drug reactions increases the more medications a patient is taking. Obviously, with multiple medications, there comes non-adherence, and sometimes that's intentional, sometimes not intentional from the patients. It can increase hospital length of stay. It can increase someone's risk to be admitted to the hospital. And also, the other risk is drug disease interactions. And what I mean by that is the medications that we use to treat certain conditions do cause other problems in our patient population. So let me give you some examples. If we use NSAIDs or TZDs or amlodipine, these can increase fluid retention in our patient population that has congestive heart failure. When we see anticholinergics, antipsychotics, benzodiazepines, and H2 blockers used, we can see an increase in CNS effects in our patient population with dementia. And there are a multitude of others. The NSAIDs, again, could contribute to further kidney impairment in our patients with CKD. Those with polypharmacy include those related to the patient and those related to our healthcare system. So in terms of the patient-related factors, obviously multiple medical conditions that are managed by multiple providers contribute to polypharmacy. Not everyone is coordinating care and on the same page. Definitely our population has chronic health conditions can be factors associated with the use of polypharmacy. And our long-term care residents also, we see polypharmacy often with this patient population. In terms of this system, we don't do a great job about updating medical records all the time, and so that could lead to polypharmacy. So doing an accurate medication reconciliation. Obviously, we know one of our other issues are poor transitions of care. So when patients transition from one setting to another, medication may not always be correct. Automated refills. While automation of e-prescribing has benefited in terms of refilling, that automated process, if we stop a medication, could continue. And so we could see a patient continue a medication and not fully understand to stop that. And also, as I've alluded to before, as we prescribe to meet disease-specific quality metrics, this contributes to polypharmacy as well. So another polling question, what percentage of your patient population age 65 and over that you care for are prescribed 5 or more daily medications? All right, so we do have a 59% response rate, and take a look at those results, which I don't see. So my apologies, I don't see the results. Amy, do you see those? So my
We do have those. We have 75%.
all right.
I'm sorry, we're having a little bit of difficulty with the poll, Tracy.
But we do have most often 75%.
Correct.
Okay, thank you, Amy. Thank you. And just to solidify that, the literature does demonstrate that 2/3 of our adult population, age 65 and over, take at least 5 or more medications a day. So you consistently see that in practice as well, it sounds like. And of those 2/3 of adults, 1/4 of them take 10 or more medications. And 91% of patients in a long-term care facility take at least 5 medications daily. So very much what you're seeing is what we are seeing in the literature. So let's talk about what deprescribing is. It's really a systematic process to identify and discontinue medications. When we do this, we have to look at the current or potential harms of the medication therapy for the patient. Do those harms outweigh the potential benefits? And in context, we have to put this in context of a patient's individual goals of care, their current level of functioning, their life expectancy, their values, and of course, their personal preferences. So this practice very much so is patient-centered. It should be a shared decision-making process. And the evidence now supports that this really is an evidence-based practice process with some guidelines that we could use if you're new to deprescribing or considering this. I do want to take a moment to just talk about the differences between proactive and reactive deprescribing. So proactively is where the collaboration comes between the patient and their support system and the care team, the interdisciplinary team, to discontinue the medications. And this is where we really look at the risk of therapy outweighing the benefit, versus reactive, where we abruptly stop a medication in response to an adverse effect, or we see a therapeutic failure. So deprescribing can be done in both means, but what I'm talking about today is more proactive, that we take the approach that we have this collaborative agreement, this patient-centered goal to help them to decrease medication use. And as we alluded to and have talked about, we do have to think about our age-friendly health systems. And the 4 M's of age-friendly care really fit well when we talk about how do we begin this process of deprescribing, how do we make this work, how do we begin these discussions with patients. So let's take a closer look at that for where we start. And in my opinion, I call it planting seeds. And so as we talk about starting deprescribing and thinking about doing that with a particular patient, we begin to plant the seed. It is estimated that 92% of older adults are willing to stop 1 or more of their medications if the provider told them or the care team told them that this was possible. And more than half, about 2/3 of our older adults really want to reduce the number of medications they're taking. They're waiting for someone to ask them. So we have to determine our patient goals of care or ask them what matters to them. We need to review their medications. So we need to make sure that we're doing a thorough check and update of their medication list. We need to review, do they have any mobility issues? Can any of those issues be tied back potentially to medications that they're currently using? And also along with this is to assess the patient, the caregiver, or the support system willingness to think about deprescribing, and really educating on the benefits and risks of deprescribing. And lastly, that they consent to do this, that they say, yes, I want to do this. I want to begin to cut back some of my medications. There are definitely some barriers to deprescribing from the patient and caregiver side as well as the provider side. And from the patient perspective, of course, there are definitely fears of withdrawal. There is a concern that if a medication is stopped, a patient will have return of symptoms for what the medication was prescribed for. And also current lack of adverse effects. They say, well, the medication isn't really hurting me, so I don't really know that I want to stop it. From the provider side, there is definitely a need for a system to deprescribe and support deprescribing in the process. So just as prescribing is a systematic process that we explain why we're doing what we're doing and why it's important to the patient, deprescribing is the same kind of process. We also see on the provider side also fears of adverse withdrawal events from medications, unwillingness to stop a medication that was started by another provider. So again, patients seeing multiple drugs started by someone else, or even practice not willing to start what a specialty service did. Cost and time effectiveness of being able to do this obviously does require some additional time with the patient to develop these goals and to do this process a little time, which we'll look at a little closer. And of course, some patients are resistant to stopping certain things. The benefits of deprescribing are to decrease those risks associated with polypharmacy that we looked at a little earlier. So reducing those disease drug issues, those adverse effects that we see. Also reducing the use of potentially inappropriate medications. The patient benefit could be a decrease in pill burden, which could increase their adherence to their current medication regimen, which would also trickle down to decreasing cost for the patient. And as I said, increase their adherence potentially. As we look at deprescribing as a process, there are really 5 steps to this process. One is we have to look at a comprehensive medication history and review what the patient is taking. We need to identify potentially inappropriate medications, determine if the medication could be stopped, and really think about prioritization in the order of how you would consider having your patient stop therapy or stop that particular medication. Definitely a discussion about planning and initiating withdrawal and supporting the patient and the caregiver through the process and documenting that this was mutually agreed upon and what the goals of care are. So you may be asking yourself, so who's responsible for deprescribing? This is actually an interdisciplinary team everyone in the healthcare system is responsible for deprescribing. Starting those conversations from the provider to the nurse to the social worker to the pharmacist, everyone is responsible for making this happen and being a support system to each other, as well as the patient and caregiver. As we look at each step, first look at the comprehensive medication history and review, and you can think about this as what is sometimes referred to as the brown bag review. So absolutely everything the patient is taking, including over-the-counter medications, supplements, herbals, everything that the patient is actually taking, and explaining to them it's not just your prescribed medications, it's those things that you may get at the drugstore or the local herbalist. When you compile this list, we want to ask the patient, what do you take this for? So looking at their report of why they take the medication. This really helps to categorize the medications. Is the medication for a disease or symptom control, or is it something that's a preventative? We also have to consider risk factors. So, of course, there are high-risk medications, and those at the top of the list, as many of you well know, are benzodiazepines, psychotropics, NSAIDs, anticholinergics in our older adult population. And our patient risk factors are age over 80, what is their cognitive ability, their comorbidities, is there substance abuse issues that we're concerned about as well, multiple prescribers, seeing multiple specialists, and past and current issues with patient non-adherence. Next, to identify potentially inappropriate medications is to really look at adverse effects. Is the patient reporting any adverse effects? Those are medications we could potentially start in our deprescribing plan with that particular patient. Looking at the harms and benefits of drug therapy. And as many of you probably know, the Beers criteria was just updated in 2023. And so looking at, are these medications on the Beers criteria? There's a whole campaign you may be familiar with called Choosing Wisely, and they give recommendations about choosing proper medication therapy for patients as well. As we, again, work down through this process, is there a lack of therapeutic efficacy of the medication? Is there a lack of indication for its use? Do no additional benefit patient? Does the patient ask us that to be able to stop the medication? And also those patients that have really complex dose regimens multiple times a day, could be high cost as well. So thinking about all of those factors to target the list. From this, next, we want to try to determine and prioritize what we could stop for a patient. So again, we want this to be patient-centered. We want this to be an individualized, well-established goal-setting, agreed upon practice with our patients. So we have to think about their preferences as well. We want to start potentially with medications that have the most harm and the least benefit that we've identified in compiling our comprehensive list. And the easiest medications to really discontinue are vitamins and supplements. And the that will during the pandemic to minimize nurse to patient contact for patients with COVID is we saw a decrease vitamins and supplements from our long-term care facilities. So they are ways that we could start to discuss deprescribing with patients. Again, I can't stress enough that this really is a shared decision-making process, and something that with each provider visit, that this deprescribing plan continues to be revisited. Because we identified being concerned about withdrawal, both from the patient and their support system, as well as the provider, we have to make sure that this is part of our plan and something that we talk about. So some medications, as you well know, benzodiazepines, we can't stop cold turkey. And so we have to think about tapering strategies. So that has to be part of the plan. We have to look at decreasing in small increments over long periods of time. It's not something that's going to be one and done and come back in a month and we'll stop another pill, and then in 2 weeks we'll stop another one. It has to be planned and evaluated over time. And just as we don't like to prescribe more than one medication at a time, because if a patient had an adverse effect, we wouldn't know what medication it was, we shouldn't make that a practice of deprescribing either. We really need to make sure this is one medication at a time and evaluating how our patient is doing. In terms of support and documentation, again, we really need to document an agreement that the patient and their family is willing to consider deprescribing and the reason why we would recommend removing certain medications. We also need to make sure that we have provided education about their concerns with withdrawal, when they should call if they're having issues, what their concerns are, and have a specific plan in place for that. We do want to monitor our patients through the deprescribing process, so maybe a follow-up call or a follow-up visit. Just to make sure that they're doing okay during the process when it initially starts. And documentation of these practices does support sustainability, and we really need to continue to share our best practices with deprescribing. There are a lot of tools and resources that are available. This list is not meant to be exhaustive by any means, but these are some of the most common ones. There's something called the Medication Appropriateness Index. We've talked about the Beers criteria and choosing wisely. For patients on anticholinergic meds, there's an anticholinergic burden calculator to consider deprescribing those medications. There's also Stop and Start. So these are screening tools available to assist with a process. And also deprescribing.org is a valuable resource as well. They have infographics and step-by-step processes to deprescribe things like anti-diabetic agents, PPIs, benzodiazepines, sleep drugs, and antipsychotics. So very helpful as you're looking to establish a practice for these particular medications. The American Academy of Family Physicians also has an algorithm to help support deprescribing, and I put this up here as well as a resource for you to ask yourself the questions about the medication. Is it inappropriate? Does it lack an indication? And so on and so forth to help you make those decisions to think about tapering or stopping. So what can you do in your individual practice? So no matter where you are in healthcare, therapy, nursing administration, provider, we can all plant seeds. We can plant seeds with patients and families. We can plant seeds with each other to think about beginning this deprescribing practice. If it is something that you're doing in your organization or your setting, you need to share what you're finding from deprescribing with the frontline staff. So patients are happy, maybe you have surveys that are completed and they are rating satisfaction that someone asked them to stop their medication. So things like CGNE or HCAPS if you're in the hospital, things like that. The patient and family comments about how the process is going and share that with everyone. Tell all the stories you can about successful deprescribing. Educate the staff about deprescribing, because as I said, it's a whole team effort. The other thing to start as we think about talking one-on-one with patients is to really review what matters most with the patient to align with medication risk versus benefit discussions. So beginning planting those seeds, what does matter most to that patient? You can add deprescribing conversations into team huddles. I know many organizations, inpatient and outpatient, that have team huddles that I could see this being appropriately used there to help, as well as care plan meetings. And again, we want to make sure that we have some type of support for our patients during this proactive deprescribing process. So maybe a follow-up call in a week or two after they leave the office or the hospital, and we have agreed upon stopping certain medications. And again, documentation of this monitoring practice is also essential. So let's take a look at a case study to make sure that we can easily take a look at a patient, comorbidities, current prescriptions, and what could we potentially start with. So PD is an 82-year-old with a past medical history of hypertension, type 2 diabetes, hyperlipidemia, stage 3 CKD, anxiety, urge incontinence, bilateral knee arthritis, spinal stenosis, and she had a CVA 3 years ago. So I want to set the stage just a bit more. She's admitted to your care community for frequent falls at home, so she's unable to manage at home. She's had 6 falls in the past 3 months and has been having difficulty managing independently at home. Her daughter lives a mile away, her granddaughter 30 minutes away. They're both supportive of PD and assist her with care needs and ADLs. Her current medication list includes glipizide XL, metformin, lisinopril, HCTZ, amlodipine, furosemide, and the indication for the furosemide is the edema that occurred with the amlodipine. Atorvastatin, aspirin, clopidogrel, ibuprofen, omeprazole, oxybutynin, and lorazepam. So she's been admitted to the care community for 72 hours. She sustains an unwitnessed fall during her stay. And her evaluation post-fall finds a blood pressure of 90/58, a heart rate of 72, respiratory rate 20, temp 37, and a pulse ox of 97 on room air. Her blood glucose at the time of the fall was 68. She's alert and oriented ×3 with no apparent injuries. So based on this, one of the questions I would encourage you to ask yourself is, what could we consider for deprescribing after this fall? And then thinking about planning deprescribing, what other medications might be appropriate to consider in our deprescribing plan. So the first thing we could think about is stopping the glipizide. the concern that she fell and her blood glucose is 68. Definitely part of our plan taking her off the glipizide would be following routine blood glucose monitoring. We could also consider HCTZ because her systolic blood pressure is only 90. And so we would want to obviously monitor her blood pressure a little closer if we're going to deprescribe the HCTZ, as well as amlodipine and furosemide. So again, I say the furosemide was started because the amlodipine caused the peripheral edema. And so thinking about improved blood pressure control, not being amlodipine, and then not having to use the furosemide. So potentially coming up with a different medication profile if her blood pressure so indicates that she needs something else. Ibuprofen, we can think about that, stopping that because of her advanced age. We can think about non-pharmacological therapies. I did tell you that she has the osteoarthritis and the spinal stenosis. We could consider Tylenol as an acceptable alternative. So thinking about discussing that with the patient and her family. Oxybutynin, if she remains incontinent, although she's on the oxybutynin, it's likely not providing benefit. So thinking of getting her off that and all the potential adverse effects, as well as the lorazepam, and checking to see how many doses per week does she use. Could we consider a slow taper off of this medication? And looking at a sleep plan for her, so looking at non-pharmacological measures to help improve her sleep. So this is down metformin, lisinopril, aspirin, continue the aspirin and the clopidogrel, the omeprazole, antiplatelet therapy, and the Tylenol for pain control could be options. These are my references used for the presentation today, and I am happy to entertain any questions you may have.
Thank you so much, Dr. White. Really appreciate that great presentation with a lot of good information. And I just wanted to remind everybody, I know we had a lot of good resources included in her presentation. And a recording will be available if you wanted to go back and check any of those resources out and maybe reference them a little bit later on. So we're just going to pause for a brief moment. Amy is going to put a link in the chat to our post-seminar survey. So if you would please take a moment to complete that survey, especially if you are an RN who is interested in applying for those continuing education hour that we're offering. And we'll just give you a few moments here to take the time now to complete that. Then we will come back for some questions, and feel free to put those in the chat while you're thinking, or the Q&A, and we will monitor both. So we'll be back in just a short moment. All right, so hopefully everyone had a few moments to at least complete or start completing that survey. And Dr. White, if you wouldn't mind stopping sharing just so that we can see everybody again, that would be great. We do have a few questions that have come up both in the chat and the Q&A. So first was just a congratulations from Janice Whitaker, that thank you so much for an outstanding presentation, such important information, and really appreciate the process and strategies that you shared, which I'm sure is shared by many people here. Then our question in the Q&A comes from Darcy Wagner. Could you please say a few words about managing this process when there are frequent hospital visits that also compound medication management?
Yeah, Darcy, that's a great question. And so I believe that this deprescribing process should happen at all care settings. So it definitely is something that we need to look at and something our hospitalist team should also consider. I can tell you personally from my own practice, on admission of patients, I will write something like Polypharmacy and do a pharmacy consult. And in that process, I will outline what medications we should not be starting on admission and potentially come up with a plan that we should follow deprescribing moving forward. So it's a great question. It's also something that should be revisited because we do know that to decrease readmissions, patients should have post-discharge appointments within, say, 3 to 7 days is typically the range I've seen in the literature with their primary care provider. And this conversation needs to continue there as well. So great question. And I see it as it's all our responsibility across the board.
Thank you. And there was just a follow-up message that it was actually Kelly who asked that question and not Darcy. But there's also a couple questions in the chat. The first comes from Kim Hitz. Are there any state regulations for attempting to dose reduce antipsychotic medications prescribed for dementia in long-term care facility patients?
That's a great question as well, Kim. And typically, as far as regulations, I believe that there has to be this is what happened in my practice in long-term care facilities in conjunction with the IDT. The pharmacist would make a recommendation to consider a dose reduction. One of those class of medications, of course, was antipsychotics. And we would, as a provider, I would need to justify why it would not be in the patient's best interest or could consider a dose reduction for that patient. So it is a practice that for many years in caring for about 10 years in caring for patients in closed dementia units, care communities, I was involved in that practice on a regular basis. I either had to justify why I wasn't doing it or do it and then follow nursing documentation of their behaviors or changes that we would have to go back and reconsider going back to the original dose. I hope that answers your question.
Thank you. We have another, more of another resource, I guess, from Erica Husser. She said, great presentation, and that you alluded to the 4 M's in your presentation, which was lovely. So to learn more about the 4 M's, everyone is welcome to go to the Penn State Ross and Carol Neese College of Nursing Project Age-Friendly Care, which can be located at their website, agefriendlycare.psu.edu, for more information about that if you have interest in that. And then Donna Fick said, great presentation and a good link to what matters, which is always very important, especially in that 4 M's framework. So she said, I got kicked off Zoom, so I may have missed this, but can you address the new recommendations to avoid aspirin in older adults for primary prevention in the 2023 Beers criteria?
Great question. No, I did not address this. at the current time, I too am trying to get up to speed with the new recommendations as well. But I definitely think that this is something that should be on our list to consider discussing with patients, especially our advanced age older adults that just take that aspirin 81 milligrams a day. And so I think this has also great potential to help decrease pill burden for some patients and looking at risk versus benefit.
And just as an additional resource, Donna just put a link to a journal article about that. Again, if anybody wants some more information with that new recommendation. Ellen Bingham just said, congratulations for you. Thank you so much for all this good information. And then another question from Janice Whitaker. Do you have any recommendations regarding communication of med changes with staff and the importance of their observation and documentation of any possible outcomes, positive and negative?
Actually, Janice, I think it just comes with good communication, and I'm assuming you're referring to a long-term care, to a care community setting. I think it's really important that the plan be outlined and discussed and agreed upon, because I think the nursing staff at the care communities really can be the ones to plant the seeds with patients and families as well to support a deprescribing practice. And then, of course, being on the same page, communicating to the team as the prescriber, hey, we're going to stop this, please watch for this. I think that becomes all the part of the care team to outline that plan, that everyone's on the same page. Oh, okay, we're going to start with trying to decrease the dose of the lorazepam. And so looking and following the behaviors, do we see an increase in that? Or stopping the glipizide, as I used in my example, and monitoring the blood glucoses. I just think that needs to come together as teamwork so that everyone knows the plan, and we are all watching to see what happens depending on what medication it is we're trying to decrease or take away.
Thank you. And I think that Janice also had a comment on the long-term care regulations. So as Beth Ann shared, long-term care regulations include standards specifically regarding unnecessary medications, requiring review and periodic reduction of meds. So there is that as well. So let's see, Kim Hintz said, thank you so much for your responses. Donna also pointed out that there is a link for the Beers 2023 New Prevention Task Force that does not recommend aspirin C 2023 Beers in reference to primary study, which is also a good summary for antipsychotics. And so thank you very much again for your presentation. And then let's see, I think that is for the questions right now. Again, feel free to continue adding those into the chat or into the Q&A. But I actually had a question for my own edification. But I know I have heard other presentations talk about like a prescribing cascade, which I think you kind of alluded to when you were mentioning in your case study how someone had a medication prescribed to deal with a side effect of another medication. So when you're thinking about ways to kind of be proactive, you know, in deprescribing, do you have any recommendations about maybe how to avoid or how to prevent that sort of prescription cascade from even getting started in the beginning?
That's a great question as well, Diane. And as we think about this, I really think the recommendation that you know, like something, I'll use the amlodipine example. If I'm going to write a prescription, or you as the nurse are concerned that your patient has increased weight and volume overload because of the amlodipine, because your patient can't get their shoes on, you know, writing a prescription for one pill to combat what the other's doing really should make us stop and think, do I really need to use the calcium channel blocker to control their blood pressure? Or have I not tried some other antihypertensives? The answer may be yes. The answer may be no. And we have to try to justify that. But I think it starts there as well, that we're all thinking about, instead of just giving you furosemide, why can't you get your shoes on today? Oh, that's because 3 months ago I started you on amlodipine. And so I think it all makes sense to keep going back to think about what we're doing, why we're doing what we're doing, and really be able to justify, you know, it is sad to say, oh, I take this because my other pill causes that.
Right, exactly. I mean, that I would think is like one of the main things you would want to avoid is that here's another pill to help with the other pill, and then a pill to help with that. Yeah. That wouldn't be good.
Yeah,
for pretty
but
much anyone.
again, I think looking at it individually is, you know, is it a viable option to have them on a different class of antihypertensive, or was this like the fourth antihypertensive and they're really refractory to what's going? And so looking at it from that context, individually, you know, about what's happening with the patient. But yeah, I think we should be asking that for everything we prescribe for people as provider.
Right. Well, we are coming up on time, but thank you, everyone. I'm not seeing any last questions in the chat or the Q&A. So again, thank you so very much to our presenter today, Dr. Beth Ann White.